Opening the hook. Okay, imagine this. Your patient is lying comfortably on the OT table. BP 130/80. Beautiful. You pre-oxygenate, give your induction drugs. Propofol goes in. Patient goes to sleep. You intubate. And then you casually look at the monitor. 65/35. And suddenly you're more awake than the patient. So what exactly happened in those 30 seconds? Why does blood pressure sometimes absolutely crash after induction? Let's make this ridiculously simple. First, what actually determines blood pressure? Before blaming propofol for everything, remember one equation. MAP approximately equals cardiac output times SVR. That's basically the whole story. Your blood pressure depends mainly on how much blood your heart is pumping multiplied by how tightly your blood vessels are constricted. So if cardiac output falls, BP falls. If SVR falls, BP falls. And if both fall together, well, congratulations. Your monitor is now screaming at you, and induction can do exactly that. 1. The arteries relax. First thing that happens, vasodilation. Before induction, your body has a certain amount of sympathetic tone constantly keeping the vascular system constricted. You induce anesthesia, sympathetic tone decreases, and many induction agents themselves produce vasodilation. So imagine your circulation as water flowing through a pipe. Same amount of water, but suddenly I've made the pipe much wider. The pressure inside drops. That's your SVR. And remember our equation, MAP is approximately equal to CO times SVR. SVR goes down. MAP follows it. But that's only part 1. 2. The veins are actually a huge deal. This part is easy to underestimate. Your veins are basically your body's blood reservoir. A large proportion of your blood volume is sitting on the venous side. Now induction causes venodilation. The veins become more capacious. So suddenly they can hold more blood. Blood pools in the peripheral circulation. Less blood comes back to the heart. That's decreased venous return, which means decreased preload. Less filling of the heart, less stroke volume, lower cardiac output, and again, BP drops. So induction isn't necessarily making your patient suddenly lose blood. The blood is still there. It's just in a much less useful place. 3. The heart may also pump less. Then we have the third component, myocardial depression. Depending on the drug, dose, and patient, myocardial contractility can decrease. So now think about what's happening. I've already reduced vascular tone. I've already reduced preload. And now the heart may also be squeezing less effectively. So, decreased contractility leads to decreased stroke volume, leads to decreased cardiac output. And our poor MAP is getting attacked from both sides. CO decreases and SVR decreases. 4. And then we start positive pressure ventilation. Here's the sneaky one. We intubate the patient and start positive pressure ventilation. Normally, spontaneous inspiration creates negative intrathoracic pressure, which helps venous return. But now we're pushing air into the chest under positive pressure. Intrathoracic pressure increases. That can reduce venous return to the right heart. So preload can fall even further. This is why sometimes the BP looks okay immediately after induction, and then after intubation and ventilation, boom, another drop. So why doesn't every patient crash? And this is the clinically important question. You can give similar induction drugs to 2 different patients. Patient number 1 goes 130/80 to 110/70. No drama. Patient number 2 goes 130/80 to 60/30. Same anesthesiologist, similar drugs. So what changed? The patient. Take an elderly patient. They may have reduced physiological reserve and impaired compensatory responses. Take a hypovolemic patient. Their preload is already low. Now you venodilate them, there's very little reserve left. Take a septic patient, they're already vasodilated, then you add an anesthetic-induced vasodilation on top of that. Not ideal. Poor LV function, the heart can't compensate by increasing stroke volume, and then there's severe aortic stenosis. These patients have a relatively fixed obstruction to LV outflow. They cannot simply increase cardiac output whenever the circulation demands it. So a major fall in SVR can become particularly dangerous. This is why induction isn't simply give drug to patient sleeps. You're deliberately changing the patient's cardiovascular physiology. So what do we actually do? When you see 70/40, don't just think BP low. Give something. Ask, why is it low? Did SVR fall? Did preload fall? Did cardiac output fall? Is the anesthetic too deep? Did positive pressure ventilation worsen venous return? Is there another cause entirely? Because treatment should follow physiology. If vasodilation is the dominant problem, you may need a vasopressor. If preload is genuinely inadequate, the patient may benefit from appropriate volume. If cardiac output is poor, simply squeezing the vasculature harder may not solve the entire problem. And sometimes it's a combination of all three. The one thing to remember. So next time the blood pressure crashes after induction, remember this. Induction can decrease SVR, decrease preload, and sometimes decrease contractility. Therefore, cardiac output decreased plus SVR decreased equals MAP decreased. Once you understand that physiology, post-induction hypertension stops being the BP is low, what drug should I give, and becomes what part of the circulation just failed, and what does this patient need? That's the difference between treating a number on the monitor and treating the patient behind the number.